So I'd like to introduce Cathy Howells. We're very pleased to have Cathy working with us, doing some webinars and educational programs that we're going to be building over time with her. Cathy obviously is an amputee physio specialist that's worked exclusively with amputees for over 25 years. She has a tremendous amount of experience in coaching and working with amputees to develop their mobility skills and abilities. She's the author of The Amputee Coach that was published in 2009, and she's currently a consultant amputee physiotherapist to APC Prosthetics. Welcome, Cathy, and thank you so much.
Thanks a lot, Scott. Welcome, everybody, to the first of the Optimising Outcomes webinars, today for low to moderately active amputees. The aims of the Optimising Outcomes series are to provide practitioners with techniques to enable clients to gain improved functioning on their prostheses. And particularly, we're going to be looking above the prosthesis, which may be a different point of view for prosthetists, but an interesting one. And hopefully it will facilitate communication between the allied health professionals who are dealing with amputees, so that we're all going to be dealing with the same training goals, same techniques, and we can provide the same feedback to patients and same motivation. Further aims of the Outcome series are to promote goal setting with clients, to revise the muscle actions that are necessary for amputee gait, and to familiarise practitioners with the correct use of walking aids and the way in which walking aids may affect amputee gait. The principles of the series are that rehabilitation should be holistic, goal-orientated, empowering, and have an athletic focus. And what does this mean? It means that the client is not just the BKA in bed 26 or the AKA with PVD in bed 49. It means that the client is a person with physical, mental, and emotional responses and consequences of amputation. And all of these elements need to be addressed for a successful outcome of rehabilitation and prosthetic training. If our treatment is goal-orientated, it recognises that the client is an individual and will have different requirements in the short term and the long term, and we need to address these with our goals. Much like starting someone on an interim prosthesis and then moving to a definitive prosthesis for the long term, we need to set short-term goals so that the patient can see that they are improving and maintaining their momentum, and we need to have long-term goals set so that there's a direction for the rehab and the prosthetic training that keeps them moving forward over the first year or two of becoming an amputee. Effective goal setting can be done with the SMART method of goal setting. And what that means is setting goals that are specific, putting down exactly what is to be accomplished. So not just walking, but how far does the person have to walk, how long do they have to wear their leg for. For example, a really specific goal might be I need to walk with my prosthesis to the corner shop, which is 250 metres. I can then have a rest and I need to be able to walk that 250 metres home. So what we've done is set out a specific goal, we've made it measurable, how far they have to walk, we might add in a time limit, how long do we want it for them to take, so that we can see how they're progressing and when they have achieved their goal. The goal needs to be achievable and it needs to be realistic, and sometimes we can help our clients with that. For example, it may not be realistic that a 70-year-old PVD below or above knee amputee is going to climb to Machu Picchu, but they certainly might be a very effective community ambulator and fit back into their current life. It needs to be relevant to the individual. It needs to be something that they actually want to do. And it needs to be time specific. We can't just set a goal and let it warble out there and go on and on. We need to set target dates for follow-up and for completion of the goal. We need to create a culture of empowerment with our clients to fully engage them in the rehab process and get them participating in their own improvement. They need to take ownership of what's happening for them. It gives them some sort of feeling of control of their lives after what has usually been a time of life when they have been extremely out of control of what's happening to them, in spiralling down to the event of amputation. So now they can start to feel positive, they can be in control by how much they are contributing with their own efforts towards their own improvement in prosthetic rehabilitation. And to do this, I expect that everybody needs a degree of strength and control. They need to be exercising outside of their rehab time and outside of their activities of daily living. We need to expect them to do this, and they need to know that. So we need to know, what are you doing? What exercise are you doing? Are you walking? And to reinforce the idea that if you don't use it, you will in fact lose it. So that muscles that are not being used, or muscles that are being used less and less, will function less and less well. Joints that are not going through their required range will stiffen up and be able to be used less and less. So we need to be overactive in what we're using to maintain and in fact improve performance. I think everybody is aware of how much amputee walking requires energy. The energy expenditure for amputees to walk, for BKAs, is from about 9 to 40% above that of an able-bodied person performing normal walking. And for a transfemoral amputee, that increase in energy expenditure rises to from about 60 to 80% above normal. So it really is a lot of energy to be able to use a prosthesis. And I take the time to explain this to my amputee clients so that they will understand that they need to achieve a certain amount of fitness, they need to have some extra strength, they need to be stretching to maintain their joint ranges of movement for optimising use of their prosthesis, and they need to have good nutrition and good periods of rest and treat themselves like an athlete, not like a patient, because really walking with a prosthesis is a kind of athletic performance in terms of its demands on the body. And remember that some of the bodies we're dealing with have been in fairly poor condition prior to their amputation, so we will need to build them up prior to their prosthetic training, and then we will need to extend them once their prosthetic training has gotten underway. So what we're in fact trying to do is create a culture that goes from a sickness model to a wellness model. Okay, they're over the hospital part of being ill and having all those negative things happen to them, like failed bypasses, failed joint replacements, illness, whether it's meningococcal disease or cancer, whatever the cause of their amputation may have been, and shifting them now into a more positive phase of their life to in fact regain their life. We want to take them from being a dependent individual to becoming more independent again into their life and participating as part of their family, part of their community. Going from a position of where they've felt powerless and all these things are happening to me, to being empowered and participating now in what is happening to them and how it's going to affect them in the long term. So it's not like they're going to you as their prosthetist and having something done to them in terms of having a prosthesis fitted, but they are going to be interacting in that scenario as well and putting effort into that activity so that they realise the prosthesis doesn't work for them. They have to put power into the prosthesis to get the maximal outcome out of that prosthesis. So we're taking them from a passive performance on the prosthesis to something that is much more dynamic. In fact, a lot of people will look at me with a surprised look on their face when I say to them, the prosthesis won't walk for you. You have to make the prosthesis walk with you. And so I'm really encouraging them to interact, if you like, with the prosthesis and use this prosthesis, and encourage them to look at it as melding the man and the machine. They're going to have to tell the prosthesis what they want from it, in how they control it and how they deliver strength through that prosthesis to the ground so that they can walk dynamically. The clients that we're mainly talking about today are in the low to moderate category, and they will include primary amputees, most elderly amputees, amputees that fall within the K1 to K2 classification, those who are using a prosthesis for mainly transferring, those who are mobilising around their homes and perhaps a little bit in the community, and people who are using walking aids. And we'll be talking a lot about walking aids today and how that affects amputee gait and how the use of those aids can be fine-tuned so that we get the optimal outcome in a desirable prosthetic gait. Firstly, though, we need to consider how amputation affects movement patterns. After amputation, some muscles are inhibited and become weak, and this can be due to a number of factors. For example, pain and surgery. So it may become painful to contract certain muscle groups. For example, if you've had an above-knee amputation, your adductors will have been cut, so it's going to be difficult for you to contract those muscles to keep your prosthesis swinging underneath you during swing phase, because that may be uncomfortable. It also creates a muscle imbalance with the abductors, which are uncut by the surgery. So they will be working much more strongly than the adductors. Some muscles will become inhibited and weak due to positioning. For example, the hip extensors. If the hip muscles are positioned, or if the hip is positioned in flexion, such as being put onto a pillow, it effectively lengthens the hip extensors, and we know that if we constantly lengthen a muscle, it will become weaker, and because it's out of its comfort zone, if you like. Some muscles will become overactive and tight as a result of amputation. This can also be due to pain and positioning. For example, the pain response, or our response to pain, is one of flexion. And this is a survival mechanism that's built into us. For example, if you put your hand out onto a hot plate, once you feel that noxious stimulus, you automatically flex everything to get away from that pain. And this happens due to amputation as well. If you've worked in the extremely acute setting, such as I have, you may have seen your amputee clients wheeled back into the ward after amputation with what I like to call a periscope stump. So you'll see them lying in a supine position, but the stump is in 90 degrees of flexion of the hip and the knee, just like a periscope being wheeled back into their room. And you realise that if you don't get that stump flat down on the bed that afternoon, you're going to be dealing with difficulties straight from day one. We need to get those range of movement happening with full extension of the hip and the knee. But because of pain, the client is flexing, and it can be difficult to straighten that limb out. Once again, positioning. If the limb is placed on a pillow, you will find that the hip flexors become tight and overactive because the hip is placed in flexion. Also, after the amputation, the client will be spending a lot of time sitting in a chair, which of course puts the hip in 90 degrees of flexion. Hopefully, if they're a BK, stump hanging down dependent. But if there is something under the knee joint as well, the hamstrings will then tighten behind that knee joint. You'll be getting the double flexion problem for the BKAs. And also muscles become overactive and tight because of the adopted movement patterns that happen after surgery. Our neuromuscular system is like a superhighway of nerve fibres, and it's plastic. It can change in response to stimuli, and the stimuli in our case is being amputation. So the first movement experiences of an amputee are predominantly flexion experiences. If you think about someone who's had an amputation, the first thing they need to do is roll over in bed, which requires flexion of the affected side towards the bed. It requires them to sit over the bed with their joints in flexion. It requires them then to stand up, and that affected side will slightly be in flexion. And then when they start to hop with an aid, again that affected side will be in flexion. They will be sitting in chairs in flexion. And they will learn that moving means flexion on that affected side. And so when they start to walk with a prosthesis, it's very common that they will start to walk and fire off down to their flexors and walk with a flexion pattern of gait rather than one of extension. And we'll be looking at that further in the webinar with some pictures that will bear that out much more clearly. So in effect, via amputation, we have created muscle imbalances. And as I mentioned, some of those muscle imbalances are due to length-related problems. So some muscles become shorter, some become longer. And if there is an associated joint restriction, we will have the development of a contracture. Remember that a lot of our clients will have started to develop contractures or tightness in their joints and muscles prior to amputation because they've been sitting around in bed with a sore or infected or gangrenous limb. So we've already got that tightness happening prior to amputation. Some muscle imbalances will be related to the preferred activation patterns, which I've mentioned, such as the survival flexion to pain pattern and the learned movement experiences of flexion, just that they're using now to get around because their movement has changed due to that amputation. And then these muscle imbalances will then be reflected in the gait pattern, so in terms of gait deviations. And these are the gait deviations we're talking about due to patient-related causes. And this is another point of the webinar that I'm delivering today, is to get people to look above the prosthesis at what's happening with the client rather than just looking at what's happening with the prosthesis underneath them to determine what's happening with the gait deviation. If we take the most common scenario of hip flexor tightness or overactivity and look at that in terms of the gait pattern, we can see what happens when this type of gait occurs. So this man's walking with the flexed knee, flexed hip during prosthetic stance. So those tight and overactive flexors result in hip flexion throughout prosthetic stance phase. There is no active extension happening at the hip joint. You'll find there'll be a resultant decrease in the intact step length. They will drop off their prosthetic toe. They'll have lengthened and inhibited hip extensors, and basically they will usually have knee flexion throughout stance for the below knee amputees as well. So we need to look at all of the components that are contained within that flexion scenario. So we need to have a look at their hip flexors, and see if they actually have that joint range of movement. Can they achieve neutral? So as we see on the left there, the pelvis is posteriorly rotated because the hip joint is flexed, as opposed to a nice flat pelvis on the right with full extension of the hip joint on the right. When we're assessing hip flexor tightness, I do the Thomas test, as it's called. We pull the intact side up to the chest as hard as possible so that we can immobilise the pelvis and not be tripped by lumbar spine and pelvic movement. And then we can apply an extension force to the affected side to see if we can straighten out that hip and achieve a little bit of extension as well. And on the right-hand side, we want to be able to achieve some hip extension. As you can see, he's got some slight hip extension, as well as some knee flexion, checking for an adequate length of the rectus femoris muscle in the case of the below knee amputee. So once we've checked for actual joint range of movement, we need to check that the muscles can work actively through that range of movement. So on the left-hand side, we're trying to assess the active range of the hip extensors, the glute max. And on the right-hand side, you can see a very common compensation for a weakened gluteus maximus in someone using their lumbar spine extensors to achieve extension of the stump up off the bed. If someone is using their lumbar spine and not purely the hip joint, they will get excessive rise of the stump off the bed. As you can see, we only have a very small range of pure hip extension, as you can see on the left-hand side, where it's being performed correctly. Most importantly is to place a hand under the anterior superior iliac spine of the pelvis on the affected side, and that ASIS should not be lifted off the bed as the patient extends their stump. So usually I put my hand under there and get the patient to feel, and that bone stays down firmly on the bed, which actually gets them activating their core muscles while they use their hip extensors to extend the hip off the bed. And lastly, we need to get clients doing hip flexor stretches right from the beginning of rehabilitation right through prosthetic training. On the left is the beginner scenario with a roll placed underneath the stump and just relaxing that hip joint down onto the bed so the stump is kept in slight extension while they're relaxing. So I say by all means have a lie down for 20 minutes every day with a roll under your stump and just relax. So we're getting a nice passive stretch on that psoas muscle. And on the right hand side we've got a more active stretch with someone who is into their prosthetic rehabilitation, and we're trying to maintain the hip range of movement during that prosthetic phase, and we get a much more active push and a stronger stretch because we can apply it through the prosthesis there in kneeling. One of the main challenges for primary amputees, and indeed all amputees, is achieving adequate weight transference onto the prosthesis. And as prosthetists, I'm sure you're aware that the functioning of your prosthetic componentry is maximised when there is more weight bearing through the prosthesis. So the sooner we can get adequate weight bearing and weight transference on the prosthesis, the better. And weight transference is purely dependent on the lateral pelvic shift that occurs during the gait cycle. Lateral pelvic shift is maximised during mid-stance. So we're looking at the client moving their pelvis over the foot while the foot is flat on the floor. And that's one of the very basic pre-gait exercises that I do, so that you can see they achieve that position of maximal lateral pelvic shift on the right there. So that we've got shoulder over hip over foot. And this is important as well because that is the position of maximal safety for the prosthesis. And that's what we want to reinforce with the client. The more you put weight on it in this safe position, the safer the prosthesis will be underneath you. If we look at the scenario of inadequate lateral pelvic shift, you'll notice that on the right-hand side, the pelvis does not shift over the prosthesis. If the pelvis doesn't shift over the prosthesis, the shoulders will. And you can see that the line of balance that I've dropped down from his shoulders drops way outside the prosthetic foot, which is going to lead to balance problems on the prosthesis. Whereas if we look at the scenario of adequate lateral pelvic shift, you can see that that line that's dropped down from the shoulder is much closer to the foot, and he's able to balance over that prosthesis much more effectively. If we add in some upper body rotation as well, he'll be balanced perfectly over that prosthesis, and the prosthesis will be in its maximal position of safety for adequate gait. I'm just going to go back so you can see that again, how far that balance line moves from the left picture to the right picture. If that foot is too far out, placed too far outset, and the pelvis doesn't follow with adequate lateral pelvic shift versus correct foot placement and adequate lateral pelvic shift, you can see the weight line is there's much less change in the weight line, so the client will be much more balanced over their prosthesis. A very important point, that one. Now, weight transference can be influenced by a number of factors. The first one is where we're using hand support. If the client is only allowed to use opposing hand support, you can see that the pelvis is not going to travel over that prosthetic foot. Whereas if we use correct hand support on the same side as the prosthesis, we're encouraging weight transference and lateral pelvic shift over the prosthetic foot. Weight transference can also be influenced by the strength of the AB ductors. So I do a lot of sideways stepping. This is also very good for that balance of your clients, and you will find that if you get them doing sideways stepping, that their balance will improve a lot quicker and their forwards walking will improve a lot quicker because they're not having to worry about transferring their weight and controlling the knee joint at the same time as they are when they're walking forwards in that antero-posterior plane. They're only worried about the mediolateral plane, and they don't have to worry about straightening their knee joint, or in the case of the transfemoral amputee, controlling a mechanical knee joint. So walking sideways is a great balance improver and strength of abductors improver, and they need to go to the side of the prosthesis and back to the other side so that we get both concentric strengthening and, most importantly, eccentric strengthening of the abductors, which helps them control the lateral pelvic shift over the prosthesis. On the right-hand side, you can see some more advanced abductor strengthening that should be happening once the client is starting to wear their prosthesis. Now, the use of walking aids can have a very significant effect on prosthetic gait pattern. Here we can see the problem with using walking aids and placing them too far forward of the prosthetic foot. If we're using walking aids and they are placed far forward, and this is a very common scenario because everybody seems to be afraid of falling forwards. They all fall backwards, but they're frightened of falling forwards. When the sticks are too far forwards, this encourages trunk and hip flexion. This will mean that your prosthesis is effectively shortened. The client will have difficulty in breaking the mechanical knee joint prior to prosthetic swing phase. They will have problems with toe clearance during prosthetic swing, and they will probably ask you to shorten the prosthesis, telling you it is too long, when it's actually a patient-orientated problem in that they're using the prosthesis in an incorrect body position. If we look at using the sticks or walking aids in the correct position, and the correct position is sticks should be at the level where the metatarsal joints would be on the prosthetic foot, you can see that extension of the trunk and extension of the prosthetic hip side is encouraged. Therefore, weight can be transferred to the front of the foot. A mechanical advantage is achieved to break the knee easily for prosthetic swing phase. They are in a position where their anatomical hip is high, and that facilitates toe clearance of the prosthesis through swing without the need for excessive shortening, and an even step length can be achieved. So you can see that he is able to step out further with his intact foot than in the other scenario. I'm just going to go back, so you can see a smaller intact step there. It's not possible to get even step lengths unless you get fully onto the prosthetic toe. If we look at the use of aids in the mediolateral plane, we can see here that the stick in the opposite hand is discouraging weight bearing, and using the stick in the same hand as the prosthesis is encouraging weight bearing. So for my clients whose aim it is to walk without aids, I will try to get them walking with the stick on the same side as the prosthesis. There's a purely mechanical reason for this, not just because it's harder for the client, and let's face it, if it's harder, we know that that's always right, because that's the goal of physiotherapy, to make their life harder. No, just joking. The work that needs to be done by the abductor muscles is much greater when the stick is used on the prosthetic side. If you drew a little line with your mind from his hip on the right hand side to the stick, you've got a little bit of relief for the abductor muscles. But on the left hand side, the abductor muscles have a big long lever of relief by using that stick in the opposite hand. So you're actually not going to get enough muscle work happening to walk without sticks. I talked about the safe position of the prosthesis, and as prosthetists you're all well aware of this. But a lot of reinforcement and training has to go into telling the client where this position is and getting them to use this position habitually. So on the left-hand side, there's nothing wrong with the alignment of the prosthesis. It's where the patient has placed it. And a lot of clients, being unsure of their prosthesis, will place it out to the side and in front of them to use the prosthesis like a strut rather than a leg, which obviously makes the weight line fall behind the knee joint, making it unsafe. We need to reinforce that every time they stand up, and they start talking to you, don't prop that foot out in front and to the side, place it underneath you, put some weight through it so that that weight line falls in front of the knee joint and their prosthesis is stable. So we are reinforcing the correct foot placement and posture of a nice extended hip, safe knee, every time they are standing with that prosthesis. Here we can see on the left what happens with the prosthesis when it's used as a strut. It will often be used to spin around on. The prosthesis should never be spun on, as that will cause them to lose the knee into flexion and end up on the floor. Placing the knee too far in front and out to the side will also cause them to lose control of it, because the hip extensors aren't usually strong enough to maintain the integrity of that knee joint. So turning to sit in a chair, turning to use the toilet is often a big problem for people and causes falls. And also that spinning on the prosthesis causes excessive rotation forces around the stump. We need to encourage them to use the prosthesis as a leg, and it needs to be placed on the ground, and they need to step around not spin on it, till they are 90 degrees in relation to the chair, then bear some weight and sit down safely. So the inherent alignment of the prosthesis is maintained while that client turns, and they're reminded to use it as a leg and sit safely rather than just a strut. Accuracy in foot placement is another very important point for performance in amputee gait. It assists in maintaining balance over the prosthesis, especially in the mediolateral plane, as I've explained before. I use a lot of walking the line exercises where the client has to walk a line and hit that line with their prosthesis every single time they take a step. It also assists in the dynamic alignment process. As you will know yourself, if they don't place the foot in the correct position every time, it's very difficult for you as a prosthetist to determine the correct dynamic alignment of that prosthesis. So a lot of training has to go into this because we're now requiring big muscles further up the leg to perform a finer motor problem or motor activity of placing that foot in the correct position. So it can be a little difficult. So we need to reinforce where that foot should go every time. And I do like people to have a look at it initially so they know where they're placing it and when it is correct. So if the foot gets placed too far medially, obviously the patient will be put off balance to the prosthetic side. If the foot is placed too far laterally of where it should be, they will be put off balance towards the intact side, and you'll get a very unstable gait happening. You'll also get problems with their lateral pelvic shift not happening as well. We also need to look at balance control when we're teaching people to use a prosthesis. Now, good balance is not about standing there ramrod straight. Good balance is about being able to move on that prosthesis and produce force and accept force without losing your balance. It's to be able to move that centre of gravity around your base of support and be able to maintain your balance rather than lose control. So there's a lot of activities we can do as therapists to get that balance happening and quite aggressively train that balance. However, loss of balance does occur and amputees do fall. So it is important to teach them how to get up off the floor. Number one, once they've hit the deck, is not to panic. Take a moment there for them to make sure they're not hurt. Then if they're at home, I will encourage them to scoot towards some sort of sturdy furniture that might help them in getting up off the floor. However, sorry about that, everybody. Just lost you for a moment there. I'll go back in case you missed it. In getting off the floor. So as I was saying, once they've hit the deck, don't panic. Check that they are unhurt and scoot towards sturdy furniture. Turn over into the 4-point kneeling position. Bring the sound foot forwards. Then push up through the hands and the sound side towards standing. Bring the prosthesis underneath you into its safe position and pause for a moment before walking off to make sure you're not dizzy. So just to recap, key exercises for optimising outcomes, and these exercises can be started well and truly prior to prosthetic training. So there's something for the clients to do in the time where they're waiting for their stump to heal prior to prosthetic healing, and it will stand them in good stead with an increase in strength in starting their prosthetic training. So they need to have a little core program, seen here with the plank exercise. They need to be doing abdominal exercises because the core and the abdominals will be used to transmit force down through the prosthetic side to the ground so that we get dynamic walking and more power through the prosthesis. They need to have progressive hip extensor strengthening, which can start without the prosthesis on the bed, and the use of the core, isolating that movement to the hip joint and getting pure glute max strengthening, which can then be progressed in the prosthetic phase, as seen on the right-hand side here with TheraBand. And I will often use visualisation exercises over the top of the physical exercise. So when they're doing these two exercises, they should be thinking about walking, and once they achieve their maximal hip extension range and contraction, they should imagine themselves coming off the prosthetic toe. That's the phase of gait that they're practicing within these exercises. Once they've got going with their gait, a way to get them off aids is to add in the upper body rotation of gait. Now this is a normal part of walking, our arm swing, and here I'm doing a technique called facilitated walking, where the client concentrates on his walking with his pelvis and feet and legs, and I am moving the arms and upper body for him. And you will feel that the body balances much better over the prosthesis once the upper body rotation is established within the gait pattern. It assists in decreasing the reliance on walking aids and balances the client over their prosthesis much more effectively. We can reinforce that arm swing and give them the idea of that arm swing if they think about marching and popping some little hand weights into the hands. Just weighting the arms increases their arm swing, and they will feel that they're walking much more dynamically over that prosthesis. In the extreme condition, you can think about watching the sprinters in the 100 metres at the Olympics and noticing how much arm movement they use and how strongly they use their arms. That's to maximise the force down through their body, down through the foot that's in contact with the ground to propel them forwards when they're running. The same situation applies with walking. We need to get that arm swing going so that we can maximise the force that they're putting down through the leg via the hip extensors with the assistance of arm swing so that they get a dynamic push off that prosthetic side and take a good step with their intact leg. So if we put all these components together, what are the indicators of a good gait pattern when a person's using a prosthesis? I think it's all about the 5 E's and the L. It's about taking even step lengths. So steps with the intact leg and the prosthesis should be the same length. When someone's learning initially, they'll want to take a big step forward with the prosthesis and a small step with the intact leg. Why do they do this? Well, number one, it's easy. Therefore, it must be wrong. No, just it is wrong. But not just because it's easy. The real reason is that they can't control the hip extension on the prosthetic side and push hard enough with their hip extensors initially to push forwards to get a good step with your intact leg. That's why their step lengths are initially uneven. So we need to get the hip extensors going to push forwards to get the same step length with the intact leg. We need to have extended hips happening during both stance phases with both legs. We need an erect trunk, not flexing, because remember, flexion of the trunk encourages inflection of the hip and shortening of the leg on the prosthetic side, and decreases the power that we can produce via the extensors on the prosthetic side. We need to be using the entire foot of the prosthesis, so achieving toe off. So you can see that this fellow has come all the way through prosthetic stance phase to get right to the toe so that he can take a really good step length with his intact leg. He can also achieve a nice high position of the hip on that prosthetic side so that he is at a maximal mechanical advantage to get his prosthesis initiated into swing phase. Our last E is the even arm swing happening on both sides, and you can see here the arm swing happening in opposition to the feet, which is correct. And lastly, lateral trunk bending, which is minimised, which if you're doing all of the things above will make lateral transition of the pelvis onto the prosthetic side easier, and you'll be able to reduce your lateral trunk bending. I hope that's been of interest to you. We'll close it up now.